Good evening, everyone. It's my pleasure to welcome you all for today's scientific meeting. We are honored to have Dr. Muthulingesh Kumar, consultant medical oncologist from GEM Cancer Center, Coimbatore, with us today. So, Dr. Muthulingesh Kumar will be presenting on the topic from MHPC to MCRPC. Can we delay the inevitable? An important discussion focusing on optimizing treatment strategies and improving long-term outcomes for patients with metastatic prostate cancer. Thank you, doctor, for taking time to share your experience with us. Over to you, sir. Please go ahead, sir.
Good evening, all. So thanks for the introduction. Thanks for the opportunity to discuss on role of ARPAs like darolutamide in HSPC. So, can we delay the inevitable from metastatic HSPC to metastatic CRPC? So, we will be discussing this today in this meeting. So, this is my disclosure. So we all know that the standard of care for any metastatic HSPCC is ADT plus 1 ARPA, irrespective of timing of metastasis, risk or volume or burden, and co-administration of docetaxel plus minus radiotherapy. So there is no role for intensification with docetaxel alone in this era. So we have a great good data from Arasens and PIS1 as well. So to add docetaxel along with ARPA to ADT in metastatic HSPC in first line. So currently this is the standard of care if the patient is fit for a triplet therapy. So early intensification strategies, if you see adding docetaxel, we have data from Charted, we have data from Stampede, we have data from JETUC 15. You know that adding docetaxel in this setting has shown overall survival benefit in terms of hazard ratios. You can see Charted and Stampede has shown reduction in the death rates by adding docetaxel. So if you see the EAU guidelines for prostate cancer, so once prostate adenocarcinoma metastasized M1 disease, so you continue castrations by giving ADT either by medical or surgical, and you look into the life expectancy of the patient, whether it is adequate or not. If not, then combination therapy is not preferred, and if yes, then you see based on the metastatic volume, so volume of the disease basically, if it is low volume or a high volume disease. So low volume disease, you can even consider primary tumor EBRT, and you can go for a doublet combination therapy, that is ADT plus ARPAs like abiraterone, prednisone, apalutamide, or enzalutamide. So for a high volume disease, particularly, it is defined usually as more than or equal to 4 bone metastasis, including more than one site outside the vertebral column or pelvis, or visceral metastasis is always defined as a high volume metastatic disease. So when there is high volume disease, then patients has to be assessed for eligibility of docetaxel also. If the patient is eligible for docetaxel, then you can consider upfront triple combination systemic therapy, which is docetaxel plus ADT plus abiraterone or darolutamide. Options has to be explored. So for whom docetaxel is a right choice? So this is the meta-analysis. We can see IPD meta-analysis from multiple randomized trials, which is a systematic review. You can see that particularly when there is synchronous high-volume metastatic disease, the patients benefit with adding docetaxel. And even high-volume metachronous disease also, patients may benefit with adding docetaxel. But if you see the low-volume metachronous disease, it doesn't favor adding docetaxel to ADT. So these set of patients, especially T4 stage, if you see from the systematic review meta-analysis, the effect of docetaxel in particularly high volume disease, patients with T4 disease has shown a significant difference in survival when you add docetaxel along with ADT than ADT alone. So if you see stage T stage 1 to 3, there is still benefit, but the difference is more pronounced in a T4 disease of high volume patients. So this is the standard of care. Of course, we had discussed ADT plus 1 ARPI plus docetaxel. So now there is no role for intensification with docetaxel alone. So as such, we have a data from both PEACE 1 and RSNs. So RSNs was the only study. If you see, it is properly prospectively designed study to investigate whether this triplet combination is of giving benefit in metastatic HSPC or not. So it is a randomized double-blind placebo-controlled phase 3 study. So it is designed to investigate particularly addition of docetaxel to addition of darolutamide to ADT plus docetaxel. So here actually metastatic HSPC patients, around 1,306 patients were included with an ECOG PS of 1 at least, and candidates for ADT and docetaxel should be there. The stratification is extent of disease and ALP levels. So if you see the randomization, it is docetaxel plus darolutamide plus ADT versus placebo plus ADT plus docetaxel. So the endpoints were OS was the primary endpoint, and the secondary endpoints were multiple time to CRPC, time to pain progression, symptomatic skeletal event free survival, time to first symptomatic skeletal event. All these are secondary endpoints. The first cycle of docetaxel was administered within 6 weeks after the start of study drug at the discretion of the investigator. But if you see piece 1 data, so it was not prospectively designed to investigate combination of abiraterone or prednisone with ADT with docetaxel, because here if you see docetaxel was one of the stratification factor. So it is basically a 2 into 2 factorial design study where even initially the standard of care was only ADT. Then later once docetaxel combination has become the standard of care, then around some 60% of patients only have received docetaxel in this trial. So basically, the stratification was docetaxel versus no docetaxel in this study. So it was actually not prospectively designed to investigate this combination. So that we have to make a note. And metastatic HSPC, you can see that here only de novo M1 disease were involved. But if you see the RSN trial where it was recurrent M1 and prior chemotherapy patients were also involved in the trial. So from this trial, again, the primary endpoint was OS, radiographic PFS, and CRPC free survival, serious genitourinary event free survival, prostate cancer specific survival, all that. So piece 1 was actually an open label study with a 2 into 2 factorial design that was only conducted in EU. So piece 1 was amended to allow for evolving standard of care with docetaxel. So initially it was ADT alone, around 273 patients, and docetaxel was permitted as a standard of care from 2015 to 2017, and 2017 to 2018 docetaxel mandatory as a part of standard of care. So around only 308 patients were it was mandatory. So in RSNs, overall 1,306 patients were enrolled. So if you see, only 61% of patients had received docetaxel in this piece 1 trial. So this is the comparison just between the two RCTs, RSNs and piece 1. Basically, darolutamide is the only ARPA prospectively tested in this combination and proven in combination with docetaxel and ADT, which prolongs the survival and delays the disease progression and pain-free survival for patients with de novo and recurrent metastatic HSPC. So if you see the recurrent de novo disease recruitment itself, RSNs have included recurrent or de novo metastatic HSPC, but piece 1 has recruited only de novo metastatic HSPC. So the primary endpoint was again OS was there in both the trials, and stratification factors were extent of disease, ALP level in RSNs, and here it was between medical and surgical ADT and ECOG PS, extent of disease, and docetaxel was there or not. So if you see 100% of patients received ADT plus docetaxel 1,306 patients, which is pre-planned in Arasens trial. But the standard of care was evolved from ADT alone to mandatory ADT plus docetaxel during the trial of Peace 1. So only 61% of patients received docetaxel as a standard of care, around 710 patients. So in Arasen's trial, if you see the outcomes primary endpoint, the OS, you can see the significant reduction in the risk of death by 32.5% with darolutamide and ADT docetaxel combination. The hazard ratio was 0.68, which is 32.5% reduction in the risk of death. So, with addition of darolutamide, the 4-year survival rate increased from 50 to 63%. The validity of early treatment intensification with the combination is supported by results from Peace 1 also. So, Peace 1, particularly, we have to analyze the docetaxel subgroup. So, where docetaxel combination was used along with ADT and abiraterone. So, abiraterone combination has shown improvement in OS compared to docetaxel plus ADT with a risk reduction of 25%. So, the hazard ratio was 0.75 in this trial. So unlike in Peace 1, the Arasens, there was early separation in the Kaplan-Meier and the lines remained separated over the time. So if you see the patients in darolutamide arm stayed on treatment for more than 2 years and longer than the patients in the placebo arm and had similar discontinuation rate due to adverse event. So the duration of treatment is also longer, so that which means the progression is like delayed, and then the treatment discontinuation rate, if you see, which is actually comparable with the placebo, which is around 10.6% in the placebo plus ADT plus docetaxel arm, whereas in the darolutamide arm it is just 13.5% discontinuation rates due to adverse events. But if you see Peace 1 trial, where the discontinuation rates were actually higher, around 17% in the combination arm than just less than 1% in the standard of care arm. So actually, darolutamide did not affect the ability to complete the full 6 cycles of docetaxel. So if you see darolutamide plus ADT plus docetaxel combination, around 87.6% patients have completed all the 6 cycles of docetaxel. Again, you can see in the placebo arm also it is 86%, but Peace 1 data have not reported the proportion of patients who completed all the 6 cycles. So it really does matter how patients are tolerating when you add a triplet therapy. So it is literally a little difficult for us to manage the triplet therapy usually. But with darolutamide, if the patients are able to complete all the 6 cycles, around 85%, it is good data. In Arasens, again, if you see the incidences of any grade adverse events, which is again similar in both the arms, any number of patients, you can see 99% here and 99% there. And if you see grade 1, grade 2, grade 3, grade 4, grade 5, if you see around 4%, which is similar in both the arms, like placebo versus darolutamide. Serious adverse events also, which is around 44 and 42% in each arms. So if you see, but in Peace 1, grade 3 events were actually more in abiraterone plus prednisone plus ADT and docetaxel arm, with additional risks of severe hypertension, hepatotoxicity when you compare with only docetaxel and ADT. So there was significant hypertension, grade 3 events, and grade 3 hepatotoxicity was around 6% in this one abiraterone arm, then which was 1% in just docetaxel and ADT arm. So all grade adverse events have not been reported for Peace 1. Severe adverse events are higher, obviously, which is seen in this table with the abiraterone arm. Whereas the incidences of adverse events of interest were generally similar between the treatment arms when you use darolutamide with ADT and docetaxel, as per the Arasens data. So incidences, of course, the rashes and hypertension were slightly higher in the darolutamide arm. Rashes, you can see 13% versus 16.6%. Hypertension, again 9 versus 13.7% in darolutamide. Apart from that, most of the adverse events were, the incidences were almost similar between the two treatment arms. You can see the seizure rates also, it is less than 1%, 0.6%. So the APCCC 2024 panelists voted on questions regarding the use of triplet. So in patients with high burden metastatic HSPC that they are chemotherapy fit, do you recommend the triplet therapy ADT plus docetaxel plus ARPA? So majority, around 54 percentage were voted for yes in majority of patients, and some 40% were voted only in selected patients, and 6 percentage usually do not recommend this combination. So a combined 94 percentage voted in favor of recommending triplet therapy either for a majority or at least for a selected patients group. And in patients with low burden metastatic HSPC that are chemotherapy fit, do you still recommend triplet therapy, that is ADT plus DOSI plus ARPA? So when it is a synchronous disease, most of the time majority agree that they would consider triplet therapy, 47%, 50%, and in selected patients around 47% have voted, and 3% of course no. But in metachronous disease, asynchronous disease, most of the time majority agree that they would use triplet therapy around 87%. So safety considerations for doublet therapy, at least for abiraterone, we should be monitoring the edema, hypokalemia, LFTs, and hypertension. Pill burden is more, and exacerbation of ADT adverse events, which is found with the doublet, and cognitive, bone health, all that we have to consider. And when you see triplet therapy, of course, we should be considering patient fitness. So we have to go through the chemotherapy toxicity, infusional treatment, administration time. All these considerations are associated with doublet therapy is also applicable here in triplet therapy. So the take home message is like the two studies which we discussed, Peace 1 and Arasens, has demonstrated that ADT plus docetaxel is not enough, and that addition of RP improves the survival. So additional intensification with a triple combination treatment approach, which is RP plus ADTA plus docetaxel, should be considered as a new standard of care in appropriate patients with metastatic HSPC to proactively manage adverse events of newer treatment options to optimize treatment outcomes like survival, quality of life. All these has to be considered. Multidisciplinary care, a key to success in prostate cancer. All eligible patients should be offered the benefits of all proven and effective treatments to enable the living with preserved or improved quality of life. So thank you for the patient listening. It's open for any questions.
Thank you, Doctor. Thank you very much for the insightful and informative presentation. The floor is open for question and answers. If you want, you can unmute and ask the question, or else you can post the question in chat box. Sir, actually, there is some two questions in the chat box, sir.
Yeah.
Yes, sir. So, sir, in your real world practice, which patient characteristics influence your decision to choose darolutamide over other ARPIs in MHSPC beyond the evidence from Arasens and Naranut?
No, definitely when the patient is fit and synchronous metastatic disease like synchronous metastatic CSPC, patient fitness I would assess, and then we should choose a triplet therapy as early as possible. Now that is the way forward so that we prolong the progression, free survival. Especially in prostate cancer, we should look into prolonging the survival with maintaining the quality of life.
Thank you, Doctor. And second question, sir. Now, for patients progressing after ADT plus darolutamide, what has been your preferred sequencing strategy? Have you observed better outcomes with chemotherapy, PARP inhibitors were indicated, or radioligand therapy?
I am not getting. Can you tell the question again?
For patient progressing after ADT plus darolutamide,
okay.
What has been your preferred sequencing strategy?
So when we have used already the triplet therapies like ADT darolutamide in the first line, once the patient progresses, definitely we should be looking into molecular profile like germline testing, all the HRR genes has to be looked into, and if at all possible, we can repeat a biopsy also to see the neuroendocrine transformation and consider chemotherapy along the lines of neuroendocrine. So definitely, if something comes up positive in HRR, we would consider PARP inhibitors. And apart from that, if the disease burden is more, we can even consider next line chemotherapy like cabazitaxel. When the bone disease is very bad, then we can consider lutetium therapy as well, like PSMA therapy, all that.
Thank
So
you,
once
Doctor.
it
Thank
becomes
you.
CRPC, we have those options. That's all.
Thank you, sir. Thank you. Sir, actually, one more question, sir. It's from my side. Actually, you are the user of darolutamide. So what is your opinion, sir? If possible, please share your...
Definitely, the tolerability is very good. We have not seen much issues like abiraterone in a triplet therapy. So darolutamide was very well tolerated, and our patients like response was also very good. Like it was almost near CR in our first PET CT itself, and he's still completed chemotherapy and continuing the darolutamide and coming for follow up under PSA is under control. So it is very good experience with this drug, and we should actually consider using in first line, definitely with a better tolerability profile.
Thank you, sir. Thank you very much. I hope there is no question from the chat or from audience. So shall we conclude the meeting, sir?
Yeah. Sure.
So thank you everyone for your active presentation and engaging discussion. We sincerely thank you, Dr. Muthulingesh sir, once again for an excellent presentation and for addressing our questions. We hope today's session has been provided valuable clinical insight that can be benefit our practice. Have a wonderful evening, doctor, and thank you very much, sir. Sir, sorry, sir, and one more question is there in the chat box, sir. Sorry, sir. Before we conclude that, do you believe triplet therapy should be considered for all fit de novo metastatic patient, or do you selectively intensify treatment based on disease burden, genomic profile, or patient frailty?
It is not easy. Even
Doctor? Doctor, your voice is not audible.
Sorry, I think I got disconnected.
Yes, sir. Yes, sir. Yes.
So it is selected patients, not for all patients.
Okay, sir. Okay, sir. Thank you, sir. Thank you very much.
Okay.
So we can end the meeting, sir. Thank you, sir. Thank you very much for joining, sir.
Yes. Thank you.
Thank you.
Thank you.
Tech team?
Yes, sir.
Tech team? Yeah, we can end the meeting.
Okay, sir. We are ending the session now.
Yeah.